So I'm Professor Fred Saad, Professor and Chairman of Urology at the Université de Montréal. So the PROpel study is a Phase III randomized placebo-controlled trial looking at patients in the first-line mCRPC setting that were allowed to have had chemotherapy prior to coming in to the study if it was received for hormone-sensitive disease. And we clearly need to do better in terms of outcomes and progression-free survival in patients in first-line mCRPC. So PROpel showed that when we combine abiraterone with olaparib compared to getting abiraterone alone, we significantly improve radiographic progression-free survival and survival by 8.6 months compared to a worldwide standard of care for mCRPC. So in terms of efficacy, clearly significant improvement, so it met its primary endpoint in terms of radiographic progression-free survival. Obviously, overall survival is an important endpoint in any study for metastatic castration-resistant prostate cancer. And given the fact that we don't have a placebo arm, patients are treated as standard of care with abiraterone, it's taking longer to get overall survival results because patients are doing well even in the control arm. But what we saw in the initial analysis is that we had an improvement in overall survival that was not statistically significant with 28% of deaths. Now we're at 40% of deaths, still interim analysis, but trending even stronger towards an overall survival improvement with a hazard ratio of 0.83 and a p-value of 0.11. So we're getting very close to statistically significant improvement in overall survival for the overall subgroup of patients included, regardless of whether or not they harbor mutations. In this updated analysis, we present more detail in terms of whether or not patients had HRR mutations that were detectable. And we see that regardless of whether they have HRR mutations or not, patients had improved radiographic progression-free survival with hazard ratios that were 0.5 for those with mutations and 0.76 for those without mutations. And both are below 1 in terms of confidence intervals. So really showing that both with or without mutations have benefit. We're also presenting specifically BRCA mutated patients. And the BRCA mutated patients had a hazard ratio of 0.23, outstanding results with the combination compared to abiraterone alone. And even those without BRCA mutations are having more than a 5-month improvement in rPFS in the non-BRCA mutated group. And if we look at blinded independent analysis of imaging, it's actually 11-month improvement in radiographic progression-free survival. So really, whether or not we have mutations, patients are benefiting, regardless of biomarkers. The clinical significance of these outcomes are that we, first and foremost, have to do better in the first-line mCRPC patient. Patients are progressing overall in 16 to 18 months in terms of radiographic progression. Survivals are still under 3 years in the first-line setting, so we need to improve our treatments because many patients don't go beyond first-line treatment for mCRPC. So these results are really clinically significant and should change clinical practice in the near future. So clearly, in the treatment paradigm, patients that are presenting for first-line mCRPC that have not yet been exposed to novel hormonal therapies, this group of patients still exists in the real world. We have data that's supporting earlier introduction of novel hormonal therapies like abiraterone, apalutamide, and enzalutamide. But in the real world, many patients are still treated with ADT alone, and this is really an opportunity to catch up and do better once they reach mCRPC. So there is still a need for this kind of therapy in the real world setting today.